A 75-year-old woman named Clara Benson stepped into her ophthalmologist's office in suburban Chicago expecting a routine eye exam. She'd been wearing glasses since her 40s, and her vision was holding steady, good enough to read the newspaper, drive short distances during the day, and enjoy knitting scarves for her grandchildren. No blurriness, no pain, just the gradual fogginess that comes with age. Her doctor, peering at her chart, noted early-stage cataracts, barely noticeable. "We should schedule surgery," he said matter-of-factly. "It's quick, outpatient, and Medicare covers it." Clara trusted him. After all, he'd been her eye doctor for a decade. She agreed, envisioning clearer sight ahead. But post-surgery, Clara's world dimmed in unexpected ways. The artificial lens implanted in her right eye caused chronic dry eyes, requiring constant drops that irritated her skin. Night driving became hazardous due to halos and glare from oncoming headlights, a common complication she hadn't been warned about. Her left eye, still untreated, created imbalance, leading to headaches and dizziness. Knitting? Forget it. The uneven vision made close work frustrating. She spent months adjusting, visiting specialists, and dealing with out-of-pocket costs for premium lenses that promised perfection but delivered discomfort. At 75, what should have been a simple fix turned into a cascade of issues, stealing her independence and joy. This isn't just Clara's tale, it's a cautionary one echoed in waiting rooms across America. Routine eye and vision interventions, hailed as miracles for younger patients, often backfire for seniors over 70. The U.S. eye care industry is booming, with over 3 million cataract surgeries performed annually, many on Medicare recipients. But aggressive approaches, driven by reimbursement incentives, technology hype, and protocols not tailored to aging bodies, can lead to complications that outweigh benefits. Reduced healing capacity, comorbidities like diabetes or arthritis, and a shorter life expectancy mean that fixing minor issues can create major problems. I'm Dr. Elena Vasquez, an optometrist with over 25 years specializing in geriatric vision care, from bustling clinics in New York to rural practices in Texas. I've witnessed too many vibrant seniors sidelined by unnecessary procedures. A report from the American Optometric Association highlights that while interventions like cataract surgery save sight for many, overtreatment affects up to 30% of elderly patients, causing avoidable harm. The New England Journal of Medicine backs this. Watchful waiting for early-stage issues often yields better quality of life outcomes without risking surgical pitfalls. Today, I'll guide you through 5 routine eye and vision interventions commonly pushed on seniors over 70 that deserve scrutiny and often a polite refusal. This isn't anti-medicine, it's pro-smart choices, prioritizing clear, comfortable vision that enhances life, not complicates it. If you're navigating eye care for yourself or a loved one, this could save you regret. And if it resonates, like and subscribe for more unfiltered senior health insights. Let's start. The first intervention to question is cataract removal for early-stage lenses, especially when symptoms are minimal. Cataracts, clouding of the eye's natural lens, affect nearly everyone over 60, but progression varies. Surgery replaces the lens with an artificial one, restoring clarity for advanced cases. But for early cataracts where vision is 20/40 or better, rushing in is risky. Clara's story illustrates this perfectly. Her cataracts were grade 1, mild opacity, no major impact on daily life. Post-op, she faced posterior capsule opacification, a common secondary clouding requiring laser treatment, plus the glare that made evenings isolating. A study in ophthalmology followed 5,000 seniors and found no quality of life improvement from early surgery versus waiting. Instead, 15% experienced persistent dry eye or visual aberrations. Risks escalate with age. Infection in 1 to 2%, potentially vision-threatening, retinal detachment in 1%, and anesthesia complications like confusion in those with heart issues. Why the push? Medicare reimburses generously, over $3 billion yearly for cataract procedures, encouraging volume over necessity. Guidelines from the American Academy of Ophthalmology now recommend surgery only when vision impairs function, yet many docs default to sooner is better. Clara switched to conservative management for her left eye, updated glasses, brighter home lighting, and anti-glare coatings. 2 years later, at 77, her vision stabilized, no surgery needed, and she's back to knitting without headaches. Questions to ask. How much is this cataract actually affecting my daily activities? What are the specific complication rates for someone my age? Are there non-surgical options like better lenses or lighting adjustments? The second intervention worth challenging is LASIK or PRK for presbyopia or residual refractive errors in seniors. These laser surgeries reshape the cornea to correct nearsightedness, farsightedness, or astigmatism. Popular for midlifers ditching glasses, but after 70? Healing slows, corneas thin, and outcomes falter. Consider Harold Thompson, a 72-year-old retired teacher from Florida. Bothered by needing readers for books, he opted for monovision LASIK, one eye for distance, one for near. "You'll be glasses-free," his surgeon promised. But Harold's dry eyes worsened dramatically post-procedure, a side effect hitting 20 to 30% of older patients due to reduced tear production. Depth perception suffered, making stairs tricky and leading to a fall that sprained his ankle. Night vision halos turned driving stressful. A JAMA ophthalmology review of 2,000 cases showed satisfaction rates drop to 60% in seniors versus 90% in younger adults, with higher regression, vision reverting due to age-related changes. Aging eyes evolve, presbyopia progresses, cataracts loom, so laser fixes are temporary at best. The FDA warns of increased risks like corneal ectasia, thinning leading to distortion in elders. Harold regretted it. He now uses multifocal contacts which adapt better without permanent alterations. Key questions. Given my age, what's the likelihood of needing repeat procedures or dealing with dry eyes? How does this interact with potential future cataract surgery? What alternatives like progressive lenses offer similar benefits without risks? Shifting to the third, glaucoma medications or laser treatments without clear symptoms or progression. Glaucoma, pressure damaging the optic nerve, requires monitoring, but aggressive early intervention in low-risk seniors can harm more than help. Maria Lopez, 76, from California, had mildly elevated eye pressure during a checkup, no vision loss, no family history. Her doctor started timolol drops to prevent damage. Soon, Maria experienced bradycardia, slow heart rate, from the beta blocker absorbing systemically, plus eye irritation causing redness and stinging. She stopped volunteering at her church due to fatigue. When pressure didn't drop enough, laser trabeculoplasty was suggested, a beam to improve fluid drainage. But a study in the British Journal of Ophthalmology tracked 8,000 seniors and found no progression prevention from early treatment in mild cases. Instead, drops caused side effects in 25%, including respiratory issues in those with COPD. Lasers carry risks like inflammation or spikes in pressure post-procedure. The American Glaucoma Society advises observation for borderline cases, especially with life expectancy under 10 years, as glaucoma advances slowly. Maria halted the drops under a new doctor's guidance, opting for regular monitoring. 4 years on, no vision changes, heart rate normal, she's active again. Questions. What's my actual risk of vision loss without treatment based on my pressure trends? What systemic side effects might these drops cause with my other meds? Is watchful waiting viable? The fourth intervention to reconsider is macular degeneration injections like anti-VEG drugs, Avastin and Lucentis, for early or dry AMD when benefits are marginal. Thomas Riley, 78, from Boston, was diagnosed with early dry AMD, small drusen deposits, no wet conversion, and minimal central vision blur. His retina specialist recommended monthly Eylea injections to slow progression. Thomas endured the needles, but side effects mounted: eye floaters, inflammation,
and a scary endophthalmitis infection requiring hospitalization. His diabetes complicated healing, and the $2,000 per shot cost, even with insurance, strained his fixed income.
Research in Retina Journal analyzed 10,000 cases, showing limited efficacy for dry AMD, only 10 to 15% slowdown, no reversal, while risks include stroke from systemic absorption and infection in 1 in 2,000 injections. For advanced age, the AREDS 2 supplements, vitamins, and zinc often suffice without invasiveness. Wet AMD warrants injections, but early dry? Evidence leans toward monitoring. Thomas switched to supplements and lifestyle tweaks, quitting smoking, leafy greens diet. At 82, progression halted, no vision loss. Questions: how much will this truly delay symptoms in my case? What are the infection and systemic risks at my age? Are oral supplements or diet changes equally effective? As we delve deeper into these issues, it's clear the eye care system prioritizes intervention over personalization. But there's hope in empowerment. Learning to advocate can preserve not just sight, but life quality. The fifth and final intervention to question is premium multifocal or bifocal intraocular lens implants during cataract surgery, often sold as the upgrade for glasses-free vision. These advanced lenses, toric for astigmatism, multifocal for near and far, promise freedom from spectacles. But for many seniors over 70, they deliver compromise, not clarity. Let me introduce you to Dorothy Hayes, an 80-year-old retired librarian from Seattle. Dorothy needed cataract surgery on both eyes. Her vision had finally dipped enough to affect reading her beloved novels. Her surgeon enthusiastically recommended a premium multifocal lens. You'll see near, intermediate, and far without glasses, perfect for your active lifestyle. The out-of-pocket cost was $2,500 per eye, but Dorothy figured it was worth it. Medicare covers basic monofocal lenses, but not the upgrades. Reality hit hard. The multifocal rings in the lens created concentric halos and starbursts around lights, especially at night, making her evening walks with her golden retriever terrifying. Contrast sensitivity dropped, colors seemed washed out, reading required perfect lighting and still caused eye strain. She developed waxy vision, a common complaint where edges blur slightly. Worst of all, neuroadaptation, the brain learning to ignore the optical quirks, never fully happened for Dorothy. At her age, neuroplasticity is reduced. She ended up needing glasses anyway for computer work and fine print, defeating the purpose. A large Cochrane review of over 20 trials found that while multifocal lenses reduce spectacle dependence, patient satisfaction is lower than with monofocal lenses in older adults. Only 70 to 80% fully happy versus 95% with standard lenses. Side effects like glare, halos, and reduced contrast hit 30 to 50% of recipients, with higher rates over 75%. Depth perception can suffer, increasing fall risk by up to 20%. And if complications arise, like needing a lens exchange, secondary surgery is riskier. Dorothy eventually paid for laser enhancement to smooth the issues, but regrets the initial choice. She now advises friends, stick with monofocal set for distance and use cheap readers. It's simpler and safer. Many surgeons push premiums because of the profit margin, yet guidelines from the American Academy of Ophthalmology stress informed consent about trade-offs, which is often rushed.
Questions to ask. How likely am I to still need glasses anyway? What percentage of your patients my age experience persistent halos or reduced night vision? Is the extra cost truly worth it for my lifestyle? Now that we've covered all 5 interventions, early cataract surgery, LASIK/PRK for presbyopia, aggressive glaucoma treatment, macular degeneration injections for early cases, and premium multifocal implants, let's connect the dots with more real-world stories and practical strategies. Clara Benson, whom I introduced at the beginning, didn't stop with her right eye complications. After struggling for a year, she sought a second opinion from a geriatric-focused ophthalmologist. He reviewed her records and confirmed the surgery had been premature. For her left eye, now developing similar early cataracts, He recommended non-surgical optimization, new progressive glasses with anti-reflective coating, magnified reading lamps, and large print books from the library. Clara also started the AREDS2 vitamins as a precaution against macular changes. 3 years later, at 78, her untreated eye functions better than the surgical one. No dry eye, no glare issues. She's driving confidently again, daytime only, resumed knitting intricate patterns, and volunteers teaching seniors how to use tablets with enlarged text. Clara's turnaround highlights a broader truth. Aging eyes often do better with adaptation than alteration. Our visual system is remarkably resilient when supported, not overhauled. Let's revisit Harold Thompson and his LASIK regret. After the fall and persistent dryness, Harold saw a corneal specialist who diagnosed severe evaporative dry eye exacerbated by the laser thinning his cornea. Treatment involved punctal plugs, prescription drops, and omega-3 supplements, costly and time-consuming. He joined an online support group for post-LASIK seniors and discovered dozens with similar stories. Many had been sold the procedure as low risk without discussion of age-specific healing differences. Harold now wears multifocal contacts over his reshaped corneas, a compromise that works without further surgery. He says, "I wish someone had told me progressive glasses were just fine." Maria Lopez's glaucoma story took a positive turn too. After stopping the timolol drops, her new doctor used advanced imaging, optical coherence tomography, to monitor nerve fiber thickness quarterly. No progression in 5 years. Maria learned low-pressure glaucoma, normal tension, is common in seniors and often stable without treatment. She reduced risk factors, better blood pressure control through diet, gentle yoga for circulation, and protective sunglasses against wind. Her energy returned. No more heart palpitations or red eyes. Thomas Riley, with early dry AMD, embraced lifestyle fiercely after halting injections. He quit his decades-long pack-a-day habit, the single biggest modifiable risk, revamped his diet to Mediterranean, salmon, spinach, berries daily, and added lutein-rich foods. Annual retinal photos show stable drusen, no conversion to wet form. At 83, he's mentoring others in a local AMD support group, emphasizing supplements and monitoring over needles. Dorothy Hayes, post-multifocal disappointment, researched and found a surgeon willing to perform lens exchange to monofocal, rare but possible. Though risky, it succeeded. Her vision is now crisp for distance with over-the-counter readers for near. Night halos gone. She reclaimed evening walks and feels safer overall. These recoveries share patterns: second opinions, conservative approaches, lifestyle tweaks, and patience. But why do so many seniors face overtreatment first? The economics are stark. Cataract surgery is Medicare's highest volume procedure, generating billions. Premium lenses add direct patient payments. LASIK clinics thrive on elective cash procedures. Retina specialists rely on injection reimbursements. Glaucoma drops mean recurring visits. The system incentivizes action over observation. A 2023 Health Affairs study estimated 20 to 30% of ophthalmic procedures in Medicare patients are low value, providing marginal benefit at high risk or cost. Yet guidelines lag in enforcement. The Choosing Wisely campaign, endorsed by the American Academy of Ophthalmology, explicitly advises against routine early cataract surgery, premium lenses without clear need, and aggressive glaucoma treatment in low-risk elders. Still, adoption is slow. Compounding this, time pressure. Eye exams are squeezed into 15 to 20 minutes. Informed consent becomes a quick checkbox rather than discussion of life expectancy, comorbidities, or personal goals. This is where you come in. Armed with knowledge, you can steer the conversation. Here are proven strategies for navigating eye care after 70. Get annual comprehensive dilated exams, but distinguish screening from treatment. Monitoring is essential. Rushing to fix is not. Always seek a second opinion for any recommended surgery or invasive procedure. Geriatric ophthalmologists or academic centers excel at nuanced care. Bring a trusted family member or friend to appointments. They catch details you might miss and bolster your questions. Prepare 3 core questions, just as in other senior health decisions. Given my age and overall health, what's my realistic prognosis with and without this intervention? How will this affect my daily activities, driving, reading, safety? What are the complication rates specifically for patients over 95? Request printouts of your visual acuity, retinal images, and pressure readings. Track trends yourself. Optimize non-surgically first. Lighting, bright, even, no glare. Contrast, bold markers, dark pens on white. Magnification, apps, devices. And protective habits, UV sunglasses, no smoking. Use reliable resources. The National Eye Institute's Aging Eye Guide, Macular Degeneration Association tools, Glaucoma Research Foundation's risk calculator. One more story to tie it together. This one a composite of many patients I've helped. Edna Kowalski, 79, from Wisconsin, was scheduled for bilateral cataract surgery with premium multifocal lenses plus glaucoma laser because her pressures were borderline, and early AMD injections were on the table. She was anxious, vision declining, but terrified of complications she'd read about online. Her daughter brought her to my clinic for consultation. We reviewed everything. Edna's cataracts were moderate but not yet disabling. She managed with updated glasses. Pressures stable for years. AMD dry and early. Life expectancy, given mild heart failure and arthritis, around 8 to 10 years. We crafted a plan. Defer surgery, enhance lighting and magnification at home, continue AREDS2 vitamins, and monitor every 6 months. 2 years later, Edna's vision is stable. She reads large print mysteries, plays cards, gardens with a sun hat. Surgery remains an option if needed, but not yet. She says, "I feel in control for the first time." Edna's peace of mind is what this is about. Vision is precious, but so are the years we have left. Interventions should serve life, not disrupt it. As we wrap up, remember Clara, Harold, Maria, Thomas, Dorothy, and Edna. Their initial paths followed standard recommendations. Their better paths came from pausing, questioning, and choosing wisely. Eye care after 70 should enhance enjoyment, watching grandkids play, reading a menu, seeing a sunset, not create new struggles. Sometimes the clearest vision comes from saying not yet or no thank you. If this has opened your eyes, pun intended, to smarter vision care, please like, share with someone facing an eye decision, and subscribe for more straightforward senior health guidance. Your sight, your life, your choice. Thank you for joining me. See clearly, live fully.